before we begin for people who are joining us for the first time. So we call this platform Exchanges in Primary Care. It is a dedicated series of insights designed for the public health community at large. So through this platform, actually, we aim to bring together frontline practitioners and experts to share their experiences and bridge the gap between theory and practice to foster collective knowledge sharing across the primary healthcare field. So today we're diving into a very critical challenge. Now, how do we deliver high quality, reliable healthcare and financial safety to patients who need it the most, especially from rural and underserved areas? So we have two guests with us from Dvara Health Finance who will be sharing their experience from Satara, Maharashtra. So our first guest today is Ms. Bindu Ananth. Uh, she is the chair and co-founder and managing trustee of Dvara Holdings and the founder of Dvara Health Finance. So she's a social entrepreneur and they'll be sharing their innovative program, the Neem program with us. It's a tech-first subscription-based model. And you all must be familiar with her work, but I'll just still share it that, her career has spanned over more than 2.5 decades now. And from the finance field, she is a very well-known figure there. She has leadership roles. She has held leadership roles in Northern Arc Capital and ICICI Bank. She's served on 3 separate committees for the Reserve Bank of India. But she's also pioneered a lot of financial inclusion initiatives, especially now in primary healthcare. With her, we also have Mr. Sachin Iyer. The Sachin Iyer is a budding public health practitioner with his education in science and later in degree in public health. He is also a part of the Dvara Health Finance team. He leads the research there. So welcome both of you, and we're excited to listen to you and your experiences.
Apita, thank you so much really for inviting us to this forum to share our work. It's great to see several practitioners here. Also to say that we followed with great admiration the work of Ajivika Bureau, Shamsarati and DHS. So this is a real honor. So Sachin and I will do this together. So Sachin, why don't you get started?
Yeah. Hi. So thanks for the very nice introduction. Let's just begin. So here today we are talking about the Neem model, which is currently active in Satara. So to begin with, health expenses and hospitalization, we know, have been a significant driver of unsecured loans. Even in our previous work by Dvara and previous work done by Bindu, we have seen that a lot of financial services were being availed for healthcare. And we were trying to look at how we can help prevent people from getting into poverty due to healthcare issues or due to certain hospitalizations, especially among earning members. To begin with, we were looking at how can we generate savings? How can we generate savings for our customers? However, we also realized that pure financing models are not sufficient because what we need is something which pays where you are getting good value for the payment done on healthcare. Currently in India, we have around 70% of all healthcare services being availed from the private sector. And very often these are being availed in like episodic ways. People are not, there's lack of continued care, there's a lack of access, which leads to people visiting a doctor only once their issues have gotten particularly bad. So our whole aim is to catch diagnosis early, generate referrals as soon as they're required rather than waiting until it gets quite bad, decrease the doctor shopping which is happening. So we also provide medicines for doorstep care. And when we provide these medicines, we are going for we are going for generic medicines because there's a lot of mistrust we have seen within the community of generic medicines. And one thing we are working on is decreasing the mistrust by providing generic medicines in an affordable manner for our patients. with a very protocol-driven care. Protocol-driven at the level of the health worker, at the level of the doctor. Uh,
Just to add, Sachin, a little bit, in fact, our first offering in this whole space was just a straightforward savings account that we thought of as a health savings account. So the idea was that expensive borrowings are hard for people. So can we substitute that with savings? And I think despite working in this space for so long, it continues to baffle me that demand for voluntary savings, even for themes like education, health, etc., continues to be quite challenging, which is when our own understanding of many of these issues, what is the composition of out-of-pocket expenditure look like? So we at that point, maybe this was a couple of years ago, pivoted to what Sachin was describing to say, rather than try to capture the little bit of financial savings that people may have available with them, which honestly is a very tough ask. Can we instead intervene in the patient journey and actually find these savings? All of what he described, I think you're all very familiar with this, but we were quite stunned to see so much wasted expenditure. Of course, in diagnostics, but also in expensive medications, travel, etc. So then the really kind of, I think, powerful insight became, can we actually create savings rather than just think about passively capturing it into a savings account? And then the starting point for us a little bit became, let's look at places, issues that are creating the most financial hardship. And it became clear that chronic diseases really are at the top of the list, partly because of delayed diagnosis, etc., but also given the long-term sort of nature of it. So to start with, we said, let's sort of focus on the big spends, which really were chronic diseases. So diabetes, hypertension, cardiovascular disease, these three became really the primary areas of focus. We've done a little bit of, I would say, smaller piloting work around chronic pain and mental health. And we can talk about that if that's of interest. But what's really scaled are diabetes, cardiovascular disease. And so we started to think about what is the service model that makes sense given that these are the issues that we are likely going to be tackling first. And one of the first decisions we made was to say, we are not going to have any clinics. Given that so much of the nature of the problem, as we understood from many practitioners, other people who had tried in the space before us, was that getting people to walk into a clinic, no matter how cost effective, how proximate it is, seemed to be a real challenge. So as microfinance people, we have some experience of going where people are rather than wait for them to come to us. So we said that let's start day one with home-based services. And in retrospect, I think it was really important to build that culture, because I think the minute you have a clinic and you have a field carder, there's always a little bit of that tension, and people would, of course, much rather, be in a clinic than in more demanding sort of field conditions. But by completely eliminating that, everybody is, working in the field. So some of those issues we were able to sidestep, and again, we can talk more about that. The other kind of strategic choice we made was the target segment. Obviously, the need for services like this is everywhere. It's rural, urban, right? Even, many of us, our families don't receive the quality of care that we think is important. So it was important for us to figure out, where is the best sort of overlap of both the need as well as where I think there were reasonable chances for success. And I think given that we were a private sector organization trying to do this in a commercially sustainable way, etc., I think all of those reasons put together, we've chosen to focus on what I think we all think of as the missing middle, more used in the context of health insurance, but really think of these as households with monthly incomes somewhere between 18,000 to 40,000 or so, living in a tier 3, tier 4 location, below block headquarters, and typically self-employed, either in farm or non-farm. In fact, a lot of I think the typical kind of customers tend to be shop owners of some kind, self-employed businesses. And I think the other interesting thing there was that there is cash, there is some willingness, there is some ability to spend. But of course, these are very time poor kind of individuals, typically a one-person enterprise. So nobody is going to put the shutter down to make a visit to a clinic if they think it is postponable. So again, this segment, while not being certainly kind of the most vulnerable economically, from a health perspectives, health shock perspective, we thought certainly vulnerable. And for us, I think we did not want to look like we were competing with the public health system in any manner, or the Ayushman Bharat scheme, etc. So I think there was also the added advantage of saying, let's work with a category which today is in any case working with the private sector, the local kind of RMPs, local providers, yet getting quite poor quality. Can we work with that segment and sort of, introduce our offering there? So all of this was really the genesis for what we call the Neem model, which we'll be talking about in detail in the forthcoming slides. Just at a high level to recap, what are the various elements? I think home-based care we talked about. Digital platform, of course, which is more about enabling all of the operations. This is not a app for the patient. We don't require any of that. A lot of what the platform enables is standardized care protocols for care delivery, particularly for the frontline health workers, and of course, safe and secure handling of patient data. So that is something that we built in-house. Interestingly, when we started, we thought that there must be plenty of I think solutions out there that we could kind of just use. But we found that most were again designed keeping a clinic in mind. And so we needed something that was a lot more supportive of our particular workflow. So we ended up having to build this. As we talked about earlier, given that we are trying to do this in a self-sustaining type manner, we are striving. We are not there yet, but we are striving to sort of at least cover costs of the program. So we have sort of envisaged it as a subscription-based model, meaning two things. One, that it is continuous. It's not one-off service. We expect it to be a continuous contact with the patient. And second, that the subscription then pools together payments for a few different things into a single payment. So access to the healthcare team, cost of medicines, insurance if it's applicable, all of that is pooled into a single payment that we collect from the customer on a monthly or quarterly basis. And again, the idea of subscriptions is pretty new in healthcare. Arpita told us that there is interest in understanding the experience, how do people continue on subscription. So we'll share some data around some of that from our experience. And of course, there are physicians very much present in the picture. The front line is a health worker, but there are doctors and specialists who are available, but only remotely, unlike health workers who are available to do home visits. These are, video consults, audio consults, as a case may be, but always with the health worker in the loop. So the whole idea is that you have the ability to access higher levels of care if you need it, but the goal is going to be to try and do at least 70, 75% through protocol data-driven health worker-led approaches for more complicated cases, comorbidities, etc. For sure, physicians play a bigger role. I earlier mentioned that we don't have any physical clinics, etc., of our own. Having said that, of course, people need access to hospital inpatient type services, no matter how hard we may try to prevent that. So what we've done is then tied up with a local network of hospitals, typically at the block or district level, secondary care hospitals, at least one per block. And where in the judgment of our physicians, patients need to be moved either for further investigations or inpatient admission. We then work with the patient, their family, and navigate them to our hospital network. So this is, I would say, broadly speaking, the elements of Neem. The piece that we completely sort of own and are trying to kind of fine tune is the frontline home-based experience. And as you can see, for some of the other things, including the inpatient, etc., we are very much looking to work with partners. Sachin?
Yeah.
You want to take this, Sachin?
Sure. Yeah. So I'll just take you through an overview of what a typical customer journey looks like. So we begin with awareness activities when we are expanding, especially to a new village, when we are expanding to a new territory. We begin with awareness activities which are done through health camps and door-to-door awareness by our team. So we have some members of our team who are also focusing primarily on awareness and sales. So these members will go door to door, conduct awareness activities within the village to generate awareness about what we're particularly doing. We also find this to be particularly important because the kind of model that we propose to our patients is something that's new to them and something that requires a lot of explanation. It's not as straightforward as saying, "Hum ek naya clinic, we are opening a new clinic over here." It's not as straightforward as that. So often we find it helpful to have somebody doing door-to-door awareness and explaining what we do offer and encouraging our patients to either, if they're already patients of hypertension or diabetes, join our care package. And if not, we encourage them to get checked and get screened to know whether they are having any suffering from any NCDs. At the level of enrollment, we collect a small basic amount. We collect like usually just rupees 50, like a token amount, which covers the screening costs. We collect the patient details and get their consent for medical data collection. We then a health worker gets assigned. So if, for example, a salesperson is the person who had done the sale, then a health worker gets assigned to the patient who will then do a home visit for this patient, collect the vitals. So our vitals typically include what you'd expect of blood pressure, random blood sugar. So we have a glucometer kit for collection of random blood sugar. We have automatic BP machines for capturing blood pressure, along with height, weight, waist measurement, temperature, etc. Along with this, we have a detailed medical history collection. So it's quite an extensive medical history collection focusing on history of diabetes, history of any cardiac events, history of BP, any kidney issues, essentially anything that a doctor would need to know when they are prescribing a medicine for this patient. Once this data has been collected and entered into the app, it is after this that there's a mandatory video conferencing call which happens with the doctor. So again, this here it is done through the mobile phone of the health worker, who then connects the digital doctor to our patient, where the doctor firstly confirms the medical history as per requirement. The doctor discusses any other health concerns the patient has. So typically, patients would have complaints either about pain or any other particular issues, or sometimes have concerns about what medicines we provide, things like that, which doctors can counsel them on that. And post this video call, they generate a prescription for this patient. Once the prescription is generated, the health worker talks to the patient, uh, explains what package would be suitable for them. So depending on whether they have hypertension, whether they have diabetes, what package would be suitable for them, what the monthly amount payment would look like. And if if the patient agrees and makes the payment, we will begin monthly home visits for this patient. Right. So in our monthly home visits, we collect the latest vitals at the end of at every month. Any changes to the medical history is collected. Um, any incidences of any health issues, any hospitalizations that have happened in the last month, and so on. And the key part of a very important part of the monthly check-in is to also raise any need for referral. So if a patient has new complaints, or a patient is not improving on their vital scores across a period of time, this is where a referral is initiated, either to the firstly to the digital doctor in case a patient has any concerns or any other complications. um, the doctor connects with the patient, understands what the concerns are, and if required, so for if somebody is having particularly concerning side effects which cannot be dealt with remote care, we then refer this patient to our hospital network. In case for the referral is of the nature of somebody's RBS values are not coming under control, then the doctor would again counsel the patient to explain the need for maybe changing medicine dosage, changing their dietary habits, changing their behavioral habits. Um, and one key part is at the end of every monthly check-in is where we are collecting our package amount at every check-in. And so is the medicine order. So once this monthly check-in happens, the medicine order is also placed and delivered to the home of this patient. Um, uh, yeah. So so we thought we'll go into detail in what I think would be interesting to this audience. But please, if you have any questions regarding any other aspect of our work, we'll be happy to go deeper into it. So firstly, just talking about the Neem 360 tool, which is our digital platform which we have developed in-house. This tool is meant to be an all-in-one tool for patient record management, data collection, prescription generation, medicine orders. All of this happens in a single application. We have an Android application that is used in the field by the health workers, by the health worker supervisors. For example, here on the screen, on the screenshot over here, I hope you can see, this is just one of our health workers' logins. She has the list of priorities for today. So there were two pending screenings which needed to be done on the day. She can see the progress she has made this week, the progress she has made this month, any pending collections, any pending visits. Further, there's a patient list where she can view the entire patient medical history. So from the beginning until now, all the vitals that have been captured, all the medical history that has been captured is all visible to the health worker. And even the medicine order which is placed is done by the health worker. So if the collection happens, the medicine order is placed and all of it is done at the health worker level. We also have web apps which are used by the doctors and used by the people working in operations, where the doctors are generating prescriptions again within the application. Operations, anyone working in operations can see the status of different patients, can see health worker performance numbers, all of it within the single in-house tool. Uh, what we have also found, the advantage of having our own in-house Android application is it has allowed us to integrate some specific tools that we have found to be necessary. So one of them is the patient audio summary. Uh, so this is an AI generated audio summary of a patient's entire medical history as per our records. What we have found is that this is quite useful, firstly, for health workers and especially health worker supervisors to quickly get a glimpse of the entire patient's history. Because a single health worker supervisor would be responsible for 500 plus patients. And it's not possible for them to remember the medical history of their patients. And they just want a quick look at what the patient's history, how long they have been with us, what package they're on, and all of that. They get it through the patient audio summary. And a very helpful side effect of it, what we found is that it's a very good way of explaining our care to patients. Since again, the application that we have, as you might have noticed, is not a patient-facing application. The application is used only by the Dvara team. So it is not immediately obvious to a patient the nature of our longitudinal care and the protocolized care that we have. And the audio summary is a very succinct, simple way of showing that we are tracking their medical history over a long period of time, and then there's a whole team around it, and there's a whole tech platform around what the patient is being uh, served with. This also helped convince some of our patients who are nervous about, or are unsure about the kind of care that we can provide. This has been quite useful for us. Um, Another tool that I'll go into detail a bit later on is the medicine identifier. But before we go there, I just wanted to mention one more key thing that we have noticed. So to begin with, I am sure I mentioned earlier that the health workers have an Android application, whereas the doctors are using web apps. Actually, to begin with, the entire platform was built as a web app. But in the low connectivity areas, what we found is that offline access and ends up being key to the data being collected at the door of the individual. In our areas, we find that very often the quality of network is not very good at the patient's households, especially for the more remote villages. So the Android application also has offline sync, where all the data can be collected offline and synced whenever the health worker next gets internet access. Yeah. So going into the medicine identifier, so one common challenge that we found was that our, I think as many of you here would know, patients often do not have complete knowledge of what medicines they are taking. I have personally met patients who thought they were taking medicines for blood pressure, whereas none of they were taking multivitamins and a blood thinner. Um, this is a very common issue, or sometimes they're just taking medicines for some other issue. They're not very clear on what it is. And of course, the person that they would ask would be the health expert who's coming to their home, which is our health worker. But our health worker again is someone who has been trained on a specific protocol, and the knowledge of all the medicines out there is something that you need to have a degree in pharma or as a doctor to do it. And what this led to was unnecessary calls to doctors, just trying to understand what medicine is. So the health worker would take a photo of the medicine, send it to the doctor, and ask, what is this medicine for? What is that medicine for? And this is particularly the case for patients who we are trying to onboard into our system. Um, so the solution to this, which we came up with, was an AI-based tool that takes for which we take a picture of the back of a medicine. Even if the medicine packet is fully opened, you just need to clean it up, take a photo of it. The app gives the response. So here you can see I have a screenshot over here. The app is saying that the brand name of this medicine, sorry, it's in Marathi. The app says that the brand name of the medicine is Good Gliptin 500, right? 500 mg. And we can see that we also have a breakup of the composition. So we have here Vildagliptin 50 mg and metformin hydrochloride 500 mg. So this helps the health worker quickly identify what medicine it is. In fact, what we found is after launching this feature, health workers were very quickly able to learn what different medicines are for. Because now that they are regularly seeing these things on a regular basis, they were able to start identifying medicines, what the medicine is for. And we also have the final thing with associated conditions. So for here, you can see it's therefore type 2 Madhumeh, there is type 2 diabetes. Right? So the health worker gets all the information that is needed at the doorstep. Firstly, of course, it saves the time of the doctors, saves the time of the health workers. That health worker does not need to wait for the doctor to get free and if the doctor is on another call. And also the doctor can focus on providing medical care rather than identifying medicines. Again, a very good side effect of this was that our health workers' confidence was significantly improved after this. Because now when they visit a patient's house, we have equipped them with a tool which is allowing them to offer much more to our patients directly. And talking about the health worker confidence, it's been a very deliberate choice for us to go for a what we call a fourth generation health worker. And this is a health worker who is working on the front line, is full-time formally employed. Though they're supervised by physicians, they are ultimately managing and coordinating the entire patient journey for the patients. They are responsible for tracking the patient's progress. They're responsible for tracking the patient's outcomes, making sure the patients get a visit, making any referrals that are required. And we believe that this has been a key part of us being able to uh, empower our health workers to do quite a lot. The fact that they're full-time formally employed in particular. And what we also have seen, so typically health workers who join us, this is their first time working in the formal sector. So in our health worker cohort, more than 90% of them this is the first time working in the formal sector, and which is again quite helpful for their confidence and in how they come across to the patients. And we have also built a career progression for these health workers where they join as junior health workers, and slowly as they gain experience and as they're able to show more skill and as they learn more, they take on more senior roles as supervisors, as trainers, and as high risk managers. So currently in Satara, all the training for new health workers is done by our first cohort of health workers, you could say. Our first cohort of health workers are now the trainers for our new health workers. They are now the supervisors who are in charge of more than 500 patients and coordinating both the logistics and providing support on the field. We also have high risk case managers who we identified as those particularly good at counseling patients, particularly good at connecting with the patients. And these high risk case managers will then take on patients who are showing particularly high vitals. For example, someone's not able to get their or random blood sugar under control, not able to get their blood pressure under control. So this high risk case manager is then able to talk to this patient, is they're able to counsel them both on diet, on lifestyle. Often we need to convince them to take medicines on time in case their medicine adherence is not good, or convince them to opt for a different medicine combination in case they are worried and they're uncomfortable with current changing the dosage that they're currently taking. Um, and moving further in this direction, what we want to do is create a cadre of health workers and create a formal credential for these health workers. So working in partnership with IHMR, which is Institute of Health Management Research, Bangalore, we have launched a diploma in community health and digital health operations. So this is a diploma that is covering modules on NCD care, first aid, phlebotomy, and diagnostic devices for the health workers that we have. And the focus here is on building skills. Firstly, clinical skills like phlebotomy. So our health workers, we have 11 health workers who have now just completed this diploma. We have these 11 health workers who can now draw blood from the vein. And this is now allowing us to offer lab blood tests for more complicated cases for the patient. So we are able to now do HbA1c tests and more complicated tests with the blood collected at the doorstep of the house, at the doorstep of the patient by our health worker cadre itself. And then we are also equipping them with patient management skills. So, as we know, a lot of the role of the health worker is as much in managing and talking to the patients as it is clinical. And a big focus here is making sure the health worker can firstly connect with the patient and also coordinate correctly between the patient and the doctor and generate referrals as required. So going a little then into how we have structured our offerings. The offerings that we have, so the main services you could say that we offer are firstly home visits which are happening every month. We have the access to the digital doctor whenever the patient needs access to the digital doctor. We have medicines which we order and deliver at the patient's house. We provide health loan support for anybody who needs health loans. And we also have integration of insurance. And we'll go a bit deeper into each of these. Um, so the most basic plan that we offer is called Neem Basic. This is a 100 rupees per month plan where the patients receive monthly home visits from our health workers. Then they have access to the digital doctor in case of any health concerns. So again, in this case, the doctor will be writing a prescription for them, but then after that, they are choosing to go to their preferred pharmacy to obtain these medicines and take them. Uh, then we have what I would say the primary driver of our business currently, which is the Neem Plus, which is 60 to 70% of our current patient cohort. These are patients who are getting monthly visits. They have access to the digital doctor, and we are also providing them medicines at the doorstep. In case anyone needs, especially someone's opting for elective surgery or in case of pregnancy, we offer health loan support for these patients. These we have also found has been a very successful in improving the patient outcomes. Because one advantage of doing medicine delivery for the patients, the health worker also has a much better track of making sure that the patient is receiving their medicines on time. Uh, and the health workers usually checking every single month, आपने कितने medicine लिए हैं. So since they're making monthly visits, so now the health worker knows they made a visit on May 5th. Now June 5th they go back and they see that no, they still have 10 medicines left, for example. So then the health worker knows they've not been taking medicines on time and they're able to follow up. They're able to talk to the patient, understand what concerns they have. Sometimes they have certain concerns. They feel they got dizzy one day and now they stop taking medicines all of a sudden. And this visibility is something that we have when it comes to Neem Plus. Thirdly, we have what we call Neem Max. This is our insurance offering. Which we have done in partnership with Care Insurance. We are giving a 3 lakh coverage for insurance. It covers accidental coverage from day one, and for things about outside of this 1 year waiting period for certain pre-existing diseases, and then everything is covered from then onwards up to rupees 3 lakhs. For this, the pricing is as rupees 7,800 yearly, though we do have other quarterly and half yearly payment options available for these patients. In this case, the Neem Max patients get all the services the Neem Plus patients are getting along with insurance. And again, how we like to think of it and how we like to talk to our patients about it is that while typical insurance is focusing on making the payments on how you would afford a payment once you're hospitalized, our goal here is of secondary prevention. So let's say someone's already having diabetes, hypertension, we want to decrease the chances of hospitalization in the first place. Uh, Yeah. So, just a quick summary of what our customer counts have looked like over the last few months. So we
I
are
can take
currently,
this. I can take this,
sure.
Sachin.
Yeah.
So just to give you a sense of the scale and retention numbers in particular, so enrollments, as Sachin described, is the entry point and the first time screening. So we do about, on average, about 500 new enrollments and screening a month. Out of that, about half, 50% of those enrolled agree to sign up to one of the packages that we described, basic, plus, or max, depending on their need, depending on their conditions, so on and so forth. That then becomes the starting point for the continuous care journey and the subscription. Um, our experience overall of renewals, which is to say somebody who signed up for a subscription, how likely are they to continue in month 2, month 3, etc. On a monthly basis, we have somewhere between 85 to 90% renewal rates, which is to say 85 out of 90 people who signed up in month 1 make a follow-up payment to us in month 2. Then in month 3, again, 90% would do that. And so obviously, I think if you think about what is the average life of onboarded customer or patient with us, that number tends to be about 7 to 8 months. Of course, working hard to see how we can improve that. But we have the patient with us at least for that much time, and we think that's a good window to start to show some measurable improvements. So overall, the cohort size is currently in Satara about 1,500 monthly active subscribers, so people who make a regular payment every single month. So just, I think, wanted to make sure that we are leaving some of, if I think about some of the, there was a question also earlier, obviously, given the focus of the program currently, a lot of the people who work with us are people who typically either have a diagnosis, are on treatment, or in about 10-15% of cases are first time getting diagnosed when we go there and do a screening. Till then they've been, just not aware of the condition. So there is a distinct sort of the typical age of a participant in a program is between 45 to 60. That's where so in some sense, I would not describe our work so much as uh, primary or preventive right now, but it's perhaps a little bit more secondary prevention in nature. So I have a diagnosis of diabetes. RBS number is, let's say, about 160, 170 at the time of measurement. And the key is to say, can we now sort of prevent escalation? Can we prevent this person ending up in the hospital with a stroke or with renal damage and so on? So that, again, given just the context, what I described to you earlier, that is sort of the space we are in. Would, of course, love guidance from this group on how do we sort of add more primary preventive elements. But given that this is a model in which customers to pay, the users to pay, it pushes us a little bit in the direction of where the issue is understood, people are already taking medicines, and then it really becomes about if I work with Neem, I get better service, I can save money on the medicines, they will help me with hospitalization. So kind of not quite a primary, and if you look at the age, etc., of the population, also that becomes clear. This is just the overall kind of clinical outcomes numbers. So given that we do, Sachin describes the journey, monthly monitoring, etc., we are able to say what is the status of the cohort. So we report monthly control rates for hypertension and diabetes. On hypertension, we roughly have a 74% control rate, by which I mean people who at the time of screening were hypertensive. At the most recent home visit that they received, 74% of them report BP below 140 by 90. And in diabetes, that number, we've been working hard to increase it, but that's currently 50%. Again, the same definition, diabetic at the time of onboarding, and in the most recent home visit, 50% of them display control. So these numbers are already significantly better than national averages, and some of the data we've seen. And I would say the big difference is, of course, the fact that the loss to follow up is minimal because we are chasing, we are going after them, we are tracking medicines, etc., pretty aggressively. Yet there is this gap, I think, particularly in diabetes. Again, would love any advice, experience from the group. Some of the particular challenges we face there, a lot of people are, kind of walking around with significant uncontrolled diabetes. We routinely every month get, I think, maybe 6, 7 patients with RBS numbers greater than 400, which, in our protocols, etc., is crisis, immediately hospitalized. But these are people who are perhaps not even on medication. There's a lot of anxiety, hesitation about, in cases where specialists are recommending insulin because the numbers are so high that oral medication is not going to be impactful. So the specialist often wants us to initiate people on insulin, at least for a little bit of a period, till the numbers are better, and then switch back to oral. But these are all met with a lot of resistance. So I think that's where the work needs to develop a bit of a sharper edge in terms of being able to build trust, persuade, communicate with family, caregivers, etc. But this is what the outcomes looks like. And then finally, just to leave you with some of the things that we're thinking about in the future, and again, you may have guidance for us, is that clearly right now it is a pretty narrow chronic disease focus, again, given the fact that we started off with a concern around spending and borrowing, etc. So that was a logical focus. Also, just given our background, etc., I'm, for example, very conservative about saying, let's do two things, but do it well rather than try to do 50 different things. So, given that health workers, for example, don't really have prior clinical knowledge, it was really important for us to say, can they do these three conditions end to end really well? Can they deliver good outcomes rather than try and be sort of a jack of all trades? But now I think there is a lot more confidence, and particularly with the senior cadre, completing the diploma program, they are significantly more skilled. We are, for example, now going to open up to more episodic care, fevers, UTIs, diarrhea, all of which so far, of course, are very much issues in the community. But we've sort of stayed clear of that. We are gradually want to sort of expand that, but it does feel like from an execution perspective, this is going to be not a trivial one. I think the tech will have to be redesigned a little bit. Training, I think one of the things that I've been very nervous about is to say that if you take a 10 standard pass worker, and if you say that every new condition you add, mental health is 1 week of training, chronic pain is another 1 week of training, then it just won't scale. Are there ways to do away with training, but embed a lot more protocol in the technology so that health workers have a set of general skills? They know how to take symptoms, they know how to take history, they know how to draw blood, but they're not necessarily getting condition into condition into condition, which then might make the whole thing a little bit hard to scale. But this is something that we are actively thinking about and trying to learn from other models. The second point, we mentioned an insurance integration. It has a lot of gaps because right now we've really taken a pretty standard indemnity cover, and an insurer was willing to work with us a little bit and say that let's add it to our existing outpatient subscription program. And the two put together will provide sufficient financial protection for families. There are lots of gaps. So, for example, today, if you are a tobacco consumer of any kind, oral, chewing or smoking, you're automatically excluded. That is 70% of our population in Satara is some sort of tobacco consumer. And of course, that is a broader public health issue that needs to be worked on. But why should somebody who chew tobacco not have access to any kind of financial protection? Even, there can be more sort of specific carve-outs, but the insurance continues to be somewhat restrictive in scope. So that is something that we are hoping that with experience and also by demonstrating to the insurer that because you're working in a setup where you're not just sitting and waiting for the person to show up in the hospital. You're actively tracking, following up, monitoring the patient. We want to demonstrate to the insurer that your claims ratios in this program will be significantly lower than elsewhere because there is a lot of active management. So that is going to be a big proof of the pudding. In fact, I think if you're able to demonstrate that, insurers have said that they'd be willing to pass on the savings to us, which also then becomes an important source of revenue for us to say that if you keep your population healthy, well managed, the difference between 15% claims rate and a 7% claim rate, we will give you that benefit as the intermediary. So those are things that we need to sort of figure out. The other thing is Satara is just an initial kind of implementation. And because we don't really have a background in health, I think it was important for us to do it properly, learn and sort of codify a lot of the pieces of the model. Now that we've done that, we are really keen to see how can we replicate the model rather than us hiring people from scratch, doing everything in district after district. Is it possible to replicate in other geographies with the right kind of partners? That to us feels feels like a more scalable approach than us trying to do it everywhere by ourselves. And so we have one opportunity now to replicate in Nalgonda district of Telangana, where the partner is actually a hospital. And the hospital has been in the community for many, many years. But they are just sort of passive, is waiting for people to show up. So they are interested to implement this as an extension and to say, so the interaction and the relationship with the person begins at home on a screening type basis. And then, for referral, of course, they will still show up to the hospital. So that's going to be, I think, an interesting test for us to say, can we make that work? Can we align the incentives of the hospital with those of the household and the patient, all of that stuff. And then finally, as Sachin mentioned, I think the key piece of the puzzle, what makes particularly adherence, high retention, etc., possible is the fact that there is human contact and there is an empathetic sort of person that the customer meets at least once on a monthly basis. And we are very excited about this diploma and a formal kind of credential for the health worker because, as we all know, the HR needs here are so vast that it's not going to be met by just doctors and nurses. There is room for a digitally enabled health worker who's savvy at using devices and kind of working closely with physicians, providing that element of outreach. But also, I think thinking about that individual's growth, career progression, how they work up to the system. We've been very inspired here by, of all the places, Alaska, which has been a real pioneer in building out community health workers that are, very skilled, trained, and do a whole range of things, including minor kinds of surgery. And they have sort of evolved good frameworks and training for all of that. So we are excited to see. So the first batch with IHMR was our health workers. But I think in the second year, a number of other organizations have signed up because many people have existing workforces, but the challenge is that they've never been formally credentialed. They can't be pulled out of the field and sent to some classroom. So the goal here has been to develop something that is explicitly designed for people who will be working in the field, maybe occasional classroom sessions locally. Medium of instruction is, whatever is the local language that they're familiar with, but there is a core focus on skills. So that is also something that we think beyond whatever implementation we do directly, this cadre itself can be quite a significant innovation for the health system. So we'll stop with that, and happy to take more questions or comments or even guidance from the practitioners. This is actually a picture from earlier today. So Sachin and I, we were at the convocation ceremony. And so the batch of 11 health workers got their diploma today. So very, very proud moment for all of us today. Thank you.
Congratulations for that. And thank you so much, Sachin. Thank you so much, Ms. Bindu, for taking us through this journey. And I think from the idea of generating savings to, what you told us about capacity building, of, whole formalizing it, also giving back to the community in a way, and talking about communication with the patient and also the outcomes that you have shown was really interesting. We have a few questions in the chat box. I think we can start with those. I think you had answered a few already. Maybe
Yeah.
you could start with.
Yeah. I'll take a few, Sachin, and you please also jump in.
Sure.
I think we want to, on the question on palliative geriatric care, etc., like I said, we are keen to start to become more comprehensive stepwise, but partly informed by what works well with this sort of setting. And then we are governed by the telemedicine guidelines. So it needs to be something that fits within those frameworks. And then also an area where people are broadly speaking, willing to pay. And so these are some of the issues that we need to balance to figure out what makes sense. Chronic pain, for example, I think there's just so much need. We see a lot of our patients spending a lot of money, getting kind of going to the informal providers for pain management. However, we were not successful at capturing that demand because when we intervened, we offered a little bit more of a physiotherapy type approach. And that's just people were impatient with that. They said, we need something that works quicker so that we can go back to work. And so I think there are multiple things that go into figuring out what are the conditions. Financial sustainability, that's the model is designed for financial sustainability. We are not there yet. Roughly, I would say that at a two blocks, we need about 3,000 subscribers, monthly active subscribers, to be profitable. Currently, we are at about half that number. But it sort of picks up traction because existing patients start to refer new patients. So the pace is picking up. So we are very much hoping that in the next 12 months, we can demonstrate a financially sustainable hub in Satara, and that then becomes important again for replication. Socioeconomic background of patients, we covered that briefly. So this is sort of missing middle, monthly household incomes between 18,000 rupees to 40,000 rupees, self-employed, not typically people who are heavy users of the public health system, but existing private sector. I think there are good suggestions that we'll take on board. We will also, in terms of publications, we outline the thinking around the health worker and that journey and capabilities, etc., in a paper which is called the Fourth Generation Health Worker. Nachiket Moore is the lead author, and some of us participated in that. We'll share that article around. And then the results from our implementation are currently being forwarded for publication. It is work done with Iyer, the research group from Pune, which is more looking into control rates, dropout rates, a little bit more of a quantitative paper, which I'll also share once it's available. Currently, no formal linkage with Ayushman Bharat or the public health system. All our referral hospitals are private hospitals. Again, these are things that we want to figure out. It's just we don't know how to have that conversation with district hospital, for example, to say, can we send our patients? What is the protocol? What do the handshakes look like? We are enabling ABA, etc., for our users in the hope that at some point, therefore, some of the data, etc., that we are collecting will become interoperable. But right now, I would say that we've not been able to establish any formal linkages with the public health system. So I hope I at least covered most of the questions. Physicians
Just on the
don't charge.
packages.
Yeah, there is no
Yeah.
separate charge for medicines, video. So part of what we've been trying to do is to say single payment. And you can then consult your health worker unlimited number of times or consult your doctor unlimited number of times, but it's a single payment that covers everything that you need to do.
We have a few raised hands. Miss Sanjana.
Hi, Dr. Mohan.
Yeah, yeah,
Hello.
yeah, yeah. No, I think thanks much, Bindu and Sachin. This was a great model to learn about, and especially in 2026 when we are sitting with this huge kind of epidemic of NCDs. Maybe 10 years ago also, such a model might have seemed a bit, strange if I use that word. But today it so well connects with our needs. And I was just reminded of, the midwifery care you have, which is a different group, but that also is a specialized care for a specific group. And maybe as the years move on and the burden of NCD becomes better understood, there might be a need for the need of for what you are doing becomes more clearly defined. So, and I think at some time later, we'll come back and we'll be talking about your model, which tested it for the first time.
Thank you, ma'am.
Yeah. And just a couple of thoughts. You were also raised about this bit of, how about compliance for this group. So one thing, and it's a problem for us also at, in Amrit clinics at BHS, how do you convince somebody who otherwise looks to be fine that he or she has to
Yeah.
take medicines? So some things that we see working is, and we talk of it as taking knowledge to people. So I'm just kind of leaving you with some ideas to
Yes.
think of and mull over. And also to say that this is a very, big group in itself. So even continuing and more focus on this group as well, more education. How does one promote lifestyle modification, which is so much connected with the, with the results. So
Yes.
these were some more ideas to bring in.
Thank you, ma'am.
Sharmishta, you had a question. You raised one. If there are any other questions.
Yeah. Congratulations, Binduji and Sachin.
Sorry, we can't hear you.
Congratulations.
Dr. Sharmishta, we're not able to hear you clearly. Maybe if you can type your question. Till then, maybe Dr. Shamsundar can go ahead with his question.
Yeah, thank you. It was a really nice session, Bindu and Sachin. I really enjoyed, especially the idea of this monthly payments and making it sustainable. I think this is something which is very useful and which is very relevant. One question I had was that for the drugs which you supplied in the monthly as a part of the monthly package, is there a fixed list of drugs that if the prescription is from this list only that would be available, or it is or the list is like it is a very like anything can go in that thing? So I just wanted, or if it is a fixed list, how big is the list? How many drugs are as a part of the formula?
Yeah, so two, three different things. One, because again, we are governed by telemedicine guidelines. There are some categories of medication, category X, etc., that are simply not applicable to us. So we leave that aside. The attempt through our protocols, etc., is to say as much as possible, stick to this, this kind of flow of medicines, dosages, etc., that are, where there is good sort of evidence, standard of care. Having said that, a lot of people have strong views on, we have this prescription, we want this particular medicine. For a long time, we were doing only generic medicines. And while the acceptance is growing, it's still really an uphill challenge. So more recently, we are testing an approach in which we say, we offer you the generic packages, and that's, obviously a lot more cost effective. A diabetic can get medicines, care, doctor consults all at 300 rupees a month, irrespective of whether they are taking, just metformin or also a gliptin or a third molecule. Everything is 300 rupees in that approach. But if you want branded medicine, we'll make that available to you. It's a higher cost. So that is an approach that we've just, with some misgivings on my part, but we are trying out because it feels like otherwise we are losing, that 50% I showed you of the conversion from people screened to people signing up. a lot of the people who don't sign up is because they don't trust generic medicines and they want their specific brand. So that is a much longer list. I think that is some 4,000 names just in these categories that we talked about. So it is fixed, but it's an expanding kind of list.
Okay.
Thank you.
We also have a question in the chat, a related question about the different package costs in terms of why we have 300, 500, 750. You want to take that?
Yeah, so I mean, it's really linked to sort of conditions. So 300 rupees is if you have either hypertension or diabetes and therefore need medications for those. 500 rupees are people who have both conditions and therefore the cost of medicines is likely to be higher. And 750 rupees is people typically with a prior history of stroke or heart attack, for whom, the medicines are more expensive and then some of the diagnostics as well. So it's really linked to the risks. So when we screen, based on a combination of vitals and the history of the patient, we stratify the risk of the patient. Based on defined rules. So some of this costing also then gets determined by the risk status and history of the patient. And primarily the variable factor is cost of medicines.
We also have a question from Rikank earlier. Any plans to expand into screening for common cancers?
Yeah, no, we are very keen. We've spoken to a few people, and I think the screening part of it we can do for sure. But I think the concern is more how can we connect all the other pieces. For example, in Satara and all of Satara, we have only one oncology facility at the district. Of course, there is the district hospital. And then there is one private onco facility in Satara town. Nothing else below that. None of our partner hospitals have oncologist capability, etc. So I think we need to just sort of figure out the partnerships and how do we make sure that we are not just screening and leaving people with a worrying kind of finding, but able to provide. So the good thing about the other conditions is we can do complete end-to-end. We can do from first-time diagnosis to hospitalization, full hospitalization support. We are fully able to enable that within a 10-15 kilometer radius. Cancer, the journey is a little bit more complicated, but we are eager because I think that is also a big one on people's mind. And although it's lower prevalence, of course, has a big, big financial impact.
Any more questions? Anyone? Thank you so much. And thank you for sharing your experiences and also for being so forthcoming with your challenges. It also made us think over them and, something that we all deal with and struggle with. And, maybe we can also look for the solutions together. And thank you everyone for joining in.
Thank you
For
so
now.
much.
Thank you so much.
Thank you. Nice.
Yeah. Bye. Have a nice Sunday, everyone.
Bye. Bye.
Bye.
Thank you.